Welcome, everyone, this afternoon to The Cold Never Bothered Me Anyway, Winter Management of Atopic Dermatitis. I'm Jen Belcher, a pharmacist with the Ontario Pharmacists Association. Before we jump in, I'd again like to thank the sponsor of this program, L'Oreal Dermatological Beauty, for their contribution to the development in the form of an unrestricted educational grant. No one but myself has had any input into the content of this presentation. But I do have the following recent relationships with commercial interests to disclose. So I have served on advisory boards or speakers bureau for the following companies. I have not received a speaker's fee for this program because I am employed by OPA and don't receive fees above and beyond my employment income. So today we are going to review how the management of atopic dermatitis can be tailored in the winter months to ensure that any of the changes to skin can be managed effectively using adjunctive treatments, non-pharmacological recommendations, and modifications to pharmacologic therapy. That being said, before we jump into that, as well as how winter conditions affect the skin, it's really important to review the anatomy and function of the skin barrier because we're going to be talking a lot about compromised skin barriers and how we want to prevent that. And we know that in atopic dermatitis, that skin barrier is compromised. Healthy skin barrier is really important because the skin's divided into those layers with the epidermis or top layer acting as a barrier to the environment, which will prevent irritants and allergens from entering the skin, prevent those from causing inflammation that can further lead to disease, and also by preventing the loss of water or moisture into the environment. So, what does a healthy epidermis look like? So, it's going to have the following characteristics. It's going to have adequate intercellular lipids. So, this is called the lipid matrix or the lipid barrier. And this lipid matrix, you can think of it kind of like the mortar in between bricks. So it's going to hold together the corneocytes in that top layer of skin, the epidermis, and it's going to ensure that everything is sort of, all fused together properly. This lipid layer requires cholesterol, free fatty acids, and ceramides, and can be depleted through a variety of different environmental stressors. Healthy skin is also going to have a physiologic or proper pH, and that's a pH between 4 and 6. So, healthy skin is slightly acidic. And when we think about ways in which the skin can become more alkaline, so some of those harsh alkaline soaps or detergents, so forth, this can cause the proliferation of microorganisms that are can damage the skin and disrupt the balanced microbiome, which is point number 3. So we want to have that balanced microbiome where all that normal flora on the skin is in balance and it prevents that harmful bacteria from overproliferating, colonizing the skin, causing disease and inflammation. So just that's really important to keep in mind as we go through the presentation because we're going to be talking a lot about how winter weather affects the skin barrier and how we can replenish the skin barrier and prevent some of those exacerbations. So, winter is here. I think everybody's probably experiencing some of that winter weather. What happens to our skin physiology when those temperatures drop? So, we know Canadian winters are notoriously harsh. It's going to affect the skin barrier function because of this interplay of different environmental factors. So, first, we're going to talk about transepidermal water loss or TEWL and humidity. And I think, instinctively, we know that skin gets drier in the winter. Why is that? So, when we think about the external environment, cold winter air is drier than that more humid spring, summer air. And this is because the dew point lowers during the winter. So, the dew point is the temperature at which air becomes saturated with moisture. This is much lower in winter, meaning that cold air holds less moisture than warm air. So people will often talk about their hair becoming more staticky, their skin being drier. This often is in relation to dew point. We don't spend all of our time outdoors, however. So what happens when we move indoors and we have that warm air? Well, situation isn't all that much better inside either. Indoor heating, especially things like forced air heating systems, will further lower that humidity of the air, exacerbating the moisture loss into the atmosphere. Additionally, when we are outside in the winter, we're often also exposed to wind, and wind increases that rate of moisture evaporation as the air travels over the skin. This can further worsen dryness and lead to cracking, fissuring, and inflammation of the exposed areas, often hands, face. We think about perioral dermatitis, some of that fissuring around the lips, and can really impact the skin barrier that way. Next, of course, when it's winter, we think cold. And what does cold do to skin physiology? Interestingly, skin actually responds to cold temperatures by downregulating sebum production. And so, with less sebaceous gland activity, this causes some of that disruption in the lipid barrier, less oil to help lock in that moisture, and this can exacerbate dryness. We also see blood vessel constriction. So, in cold weather, our peripheral blood vessels, of course, constrict to conserve heat loss through the skin. This reduces the cutaneous blood flow and will also, in addition to reducing that heat loss, will impair the delivery of nutrients and oxygen to the epidermis, which can impact its health. Also, we have temperature changes or temperature swings. So this is those rapid shifts in temperature when we go from the very cold outdoor air into a warm indoor environment. These sorts of temperature shifts can trigger flare-ups and inflammation and actually worsen itchy and inflamed skin that's associated with atopic dermatitis. Well, when it gets cold, what do? We turn up the heat, and we talked about the impact of that on the with the forced air heating systems or heating systems and the loss of humidity in the air. But additionally, for those of us that don't all immediately go to the thermostat, and we have parents that have often told us, no, put on a sweater first, we think about the impact of protective clothing that's in contact with the skin. So in this case, we think about textile-induced irritation. So some fabrics that we use in winter clothing, we think about wool or other synthetic materials. These can cause mechanical irritation and inflammation. And in patients with atopic dermatitis, you might also see a contact dermatitis to some of this protective clothing. Regardless of the cause of the dermatitis, it is going to impact that skin barrier function and contribute to that cycle of inflammation, itching, and what have you. But because these are categorized as two different conditions in the Ontario scope of practice when it comes to minor ailments, it is important to differentiate where there could be contact dermatitis as opposed to just perhaps a flare of the atopic dermatitis that a patient may have experienced in the past. And we just think to that history and that assessment process to ensure that we're adequately assessing the patient's needs overall. Additionally, when we put on protective clothing, if it's not breathable, it can trap heat against the skin. Now, this is some cases is what we want. We want, warm air to be retained against the body in order to help keep the body warm. But where there are non-breathable layers, this can trap both heat and sweat close to the skin and disrupt the skin's natural moisture balance, as well that skin pH and microbiome. Now we do see, changes to sweating patterns, of course, in the winter. We actually see some of that, adjustment, but with that trapped heat against the skin, that can cause some of these changes to the environment immediately close to the body because of the protective clothing that we use to lock out that cold. If that weren't enough, we also have other winter stressors on the skin. So, of course, UV radiation is present year round, and the exposure from sun is still significant even in the winter. We often think about UV radiation, on summer vacation, when we're out in clothing that exposes more of the skin, we want to prevent sunburn. We think about it on tropical vacations during the winter. But it is really important to remember that even with, the winter conditions, that UV radiation is present year round and that reflection off of the UV rays off of snow can actually intensify the exposure. UV damage does further compromise skin barrier, and that damage and inflammation can cause increased water loss. When the temperatures are cold out, a hot bath or hot shower often sounds really comforting, but showering or bathing in hot water can further disrupt and deplete the lipid barrier, which will increase the dryness and transepidermal water loss, further exacerbating that itchy skin. Lastly, stress. Of course, we know that there is a strong correlation between stress and atopic dermatitis flares. And in periods of stress, which can be associated with winter months, whether we think about, things like seasonal affective disorder, holiday stressors, just overall the impact of seasonality on stress, this has the potential to worsen patient symptoms such as itching, redness, and skin irritation. That relationship, of course, between stress and flare-ups is complex, has both physiologic and psychologic factors, but we'll talk about stress in some of that non-pharmacologic management of the condition further on in the presentation. So just to review, what goes wrong with skin when winter comes? So we know that cold and low humidity will increase the water loss within the skin, impair the skin barrier function, and further exacerbate the atopic dermatitis symptoms. This can often lead to inflammation, and other conditions can also trigger inflammatory responses in the skin, which will have that increased redness, itching, and flare up. Stress and cold exposure can also dysregulate the immune system, which will cause increased T cell activation, pro-inflammatory cytokine production, which will further contribute to the pathophys of atopic dermatitis. Pruritus and itchiness, of course, one of those hallmark symptoms of atopic dermatitis that is particularly bothersome and affects quality of life. That increased stress level, dry, cold air, all of these can worsen the itch scratch cycle and exacerbate those symptoms of atopic dermatitis. And of course, lastly, we talked about the importance of skin microbiome and a healthy epidermis. So that alterations in skin microbiome because of winter environment or things like protective clothing can play a role in the development progression of symptoms. So now that we know what can go wrong with skin when the temperatures drop, what can we do about it? And fortunately, there are plenty of things that we can do to help patients adjust their therapy so that going into the winter months, they can hopefully help prevent some of these flare-ups from occurring and just maintain that sort of level of symptom-free comfort. But additionally, we can also look at perhaps, treating some of the symptoms through some of these adjunctive recommendations to therapy. So really, some of the cornerstone recommendations that we can make for patients that can be really effective in maintaining that comfort and improving quality of life are recommending gentle cleansing and proper moisturization. So what does that mean when we talk about these two recommendations? So when we're looking for a cleanser for skin with atopic dermatitis, we want to use something that is hydrating, something that's fragrance-free and has a physiological pH. We want to do this to avoid irritation and dryness during the winter months. So we think about some of these cleansers. Examples would include things like CeraVe hydrating cleanser, Spectragel. One of my personal favorites is the Lipicar Syndet that can be used to replace any sort of harsh alkaline soaps, body washes. Recommend to patients you take those right out of the shower so you don't grab the wrong bottle by mistake and use those hydrating fragrance-free cleansers. Now, this is a recommendation that we would like to emphasize year-round, but it's especially important due to that disruption to the lipid barrier and to that skin protective function throughout the winter months. Next, of course, is to moisturize regularly. And I'm going to skip a point here for just a moment. And because we've just talked about cleansing, when we're talking about bathing, using the moisturizer within 3 minutes of getting out of the shower or bath to lock in the hydration, that water that has been absorbed into the epidermis from being exposed to the water in the shower or bath. So that moisturizing immediately after bathing, but then, of course, regularly. So regular moisturization is known that it can treat mild atopic dermatitis and prevent exacerbations. So really stressing the importance, if patients don't do anything else out of what we recommend, this would be the one thing. And that would be to moisturize regularly, especially leading up to the winter months. So as things become drier, more severe in terms of the weather, recommend to patients that they consider increasing their application frequency. And they could potentially change or layer products to use heavier, more occlusive or emollient moisturizers to combat dry, cracked skin during the winter months. So you might have patients using multiple moisturizing products. At the very least, we want to ensure that they're fragrance free and that they contain good balances of the different moisturizing ingredients. We'll spend a lot more time on that later on in the presentation as well. But some of the things that we think about here are there's lots of options at various different price points, lots of different textures, and we can help patients with those selection for those moisturizers that they'll really need to help treat and prevent atopic dermatitis. Lastly, of course, is to continue good broad spectrum UV protection throughout the winter on any and all exposed skin to reduce that UV injury and damage to the skin barrier through UV radiation damage. We've talked a bit about those adjunctive recommendations, which are sort of those OTC, front shop type items. Additionally, there are many non-pharmacological recommendations that we can help patients with and reinforce going into the winter months that, if we somewhat let these slip throughout the summer, if we don't tend to have as many flares or exacerbations, really important to highlight the importance of maintaining these non-pharm recommendations, lifestyle modifications as we go into winter to help prevent those flares. So I mentioned before, a hot bath or shower sounds lovely when the air around you is cold and you're looking to warm up. However, that hot water will strip the skin of its natural oils in that lipid matrix that helps hold those skin cells together and helps prevent that water loss. This, of course, will exacerbate symptoms. Use lukewarm water, ideally only, and try to avoid exposure to any of that hot water through bathing or things like prolonged periods in hot tubs. As well, we can humidify the air. So we talked about the impact of environmental humidity on transepidermal water loss. So in, individual rooms, we can use portable cool mist humidifiers to add moisture to the air. Additionally, if the patient is able to, they could consider, if they don't already have one, a whole home humidifier that's added to their forced air system to increase that whole home humidity level, try and maintain a less dry environment within their home. Looking to specifically avoid irritants where possible, so steering clear of harsh soaps, detergents, and fragrances that can trigger flare-ups. We think about things like laundry detergents, those body washes or soaps that we talked about in the cleansing slide, about perhaps even removing those from the shower or bath area to avoid using them accidentally, and just trying to choose fragrance-free, non-irritating products to help maintain that skin comfort. Additionally, we want to counsel patients to wear loose and breathable clothing, so to avoid any of that mechanical irritation, friction from too tight clothing, as well as choosing natural fibers like cotton and bamboo that will allow the fabric to breathe and wick moisture away from the skin. This will help maintain the skin dryness, not trapping skin or heat close to the skin, and not causing that over proliferation of damaging microorganisms. Lastly, of course, helping our patients where they can to manage stress levels, as winter season can be quite stressful for some individuals. So, emphasizing the impact, of course, of things like meditation, yoga, deep breathing in that stress reduction techniques, customizing those recommendations to what works for the patient. I mentioned we were going to spend some time on moisturizers, and I think this might be one of the most important slides out of the entire deck here. So, when we think about moisturization, we're looking to replace water that's lost through transepidermal water loss and also prevent that water loss from continuing to occur. So, moisturizing ingredients can be divided into three broad categories. Most products contain a mix of all three, of course, in different proportions using different ingredients. When we are helping patients choose moisturizers, it really comes down to their medical condition, their symptom presentation, their personal preference for things like texture, brand, price point, etc. It's really important to understand the different components that go into these, because looking to choose and customize these recommendations across season may just be looking at products that tend to be more emollient or occlusive in the winter months. But the first category on the left are the humectant ingredients. So these are ingredients that are hydrophilic. When applied to the skin and absorbed into the skin, they pull water from the middle layer up to the top layer of the skin, increasing the hydration of the epidermal layer. Now, I want to spend a little bit of time on this because most people incorrectly assume that humectants are used to draw moisture from the atmospheric air into the skin, not drawing water from that middle layer, deeper in the body up towards the epidermis. And this is why humectants can work during the winter when atmospheric hydration levels are quite low, and why they can work under things like occlusive layers that are applied on top, which theoretically would prevent atmospheric humidity from entering the skin. And this is because atmospheric humidity really only is able to enter the skin when the humidity levels meet or exceed about 80%, which is quite humid and often not what we're exposed to. That majority of the water content that's being attracted through these humectants is coming from inside the body, and this is where, of course, that the importance of proper hydration, drinking enough water, is really important, not just for overall health, but for skin health, and why those hydration levels have such an impact on the appearance, texture, and comfort of the skin, because that's where that water content is coming from. This also makes sense when we think about transepidermal water loss, when we're pulling water from lower layers of the skin up into those higher levels. If we don't have enough emollient or occlusive ingredients present within the moisturizer, that can actually increase the rate of transepidermal water loss because we're pulling that water up to that surface where it can then be lost through that evaporation at that top layer of skin into the environment. This is actually how, when people will tell you that they are quote unquote addicted to lip balms, um, often those lip balms don't include enough emollient or occlusive ingredients. They have too many humectants and not enough that is sealing that moisture in. And so you're seeing that increased water loss because that water is being drawn from the deeper layers of tissue up to the top and being lost through evaporation, further contributing to dryness. Patients will then apply more lip balm and just go through that feedback loop where it actually worsens and what they believe to be the cure actually worsens the issue itself. So when we think about humectants, ingredients that we'd look for that are hydrophilic and will perform this sort of function are glycerin, urea, propylene glycol, hyaluronic acid, aloe vera, panthenol. Honey is also a humectant, so you'll see that in many skincare products. And not listed here, but also alpha hydroxy acids, such as glycolic, lactic, so forth. Those are also classified as humectants. So humectants on their own in high concentrations with low emollient and occlusives can not only increase transepidermal water loss, but also be highly exfoliating as well. And so just something to keep in mind that way when we think about the skin cycle. Next, in this middle category, we have emollient ingredients. So these are ingredients that basically replenish the lipids that are lost in that lipid matrix or that mortar holding those bricks of skin cells together. So this smooths the skin by filling in those gaps, replenishing those lipids that are lost and that are inadequate in that compromised skin barrier. And it will smooth the rough skin because it's filling in those gaps between the cells. When we think about things like flaky, dry skin, filling in those gaps will help with that. Ingredients that are emollient are things like dimethicone, ceramides. You'll see those in many, many ingredients in moisturizers, shea butter, fatty acids from plant oils and butters, so like jojoba, coconut, cocoa, and anything that you see there, typically that talks about like oil or butter, typically falls into this emollient type group. Lastly, we have the occlusive ingredients. These, rather than working like emollients where they fill in the gaps between cells, these more sit on top of the skin and they prevent water loss by forming that hydrophobic barrier on the skin surface, sort of locking everything in. Examples of this include things like petroleum jelly, beeswax, lanolin, mineral oil, and squalene. Of course, silicones on top of that as well, too. So when we think about the different components and moisturizing ingredients that will occur in different proportions, when we're reading ingredients lists, ingredients that occur closer to the top of that ingredient list will be in higher proportion as compared to ingredients that are further down on the ingredients list. So, looking for more emollient and occlusive moisturizers in the winter months will often help with reducing the impact to skin barrier that some of these winter conditions have. And then switching to lighter, more hydrophilic, watery type formulations in the summer where we aren't quite as concerned at that extensive water loss through moisturization and can give perhaps less of a greasy texture if that's a patient's preference. Additionally, when we think about therapy, if patients are using multiple topicals, helping them order the application if they're applying one after the other. One of the sort of rules of thumb that can be easy for patients to internalize is often this idea that we're looking at applying thinnest to thickest, so most hydrophilic to most hydrophobic, to prevent highly occlusive formulations from stopping the absorption of more hydrophilic ingredients if they're applied over top. That being said, of course, reviewing that, humectants applied underneath the occlusives can work because they're pulling that water from the middle layers up into that top layer, and then the occlusive layers preventing the evaporation off. When we think about moisturizers, of course, in formulation, there are so many different options out there. And additionally, looking for some of those soothing ingredients, I do have to give just a shout out to the Lipicar balm. I have a son who has eczema, and in sort of the Frank's Red Hot, we put that stuff on everything, use it everything through to a lip treatment. And then, of course, after baths and showers, and we find it particularly soothing with the effect of the thermal water on the skin when we're looking at atopic dermatitis during the winter. I do find it slightly heavy throughout the summer months, and switch to alternative moisturizers that are fragrance-free, high in ceramides and humectant type ingredients. But when I'm looking at a moisturization shift into the winter, I will often rotate through to that particular product, and do find that most patients that I recommend it to find it particularly helpful at this time of year as well. So we've talked about the impact of moisturizer formulation on its effect. Now, when we go into more of the prescription options and we think about treatment modifications, we can also think of formulation adjustments to prescription therapy. So, in topical therapies for atopic dermatitis, there are many different dosage forms, everything from things like gels, foams, lotions, creams, up to ointments. And we could consider selecting more moisturizing topical therapies if a patient is requiring that when we're thinking about prescribing any of those topical agents. Of course, if we are looking at changing from something like a lotion to or a cream to an ointment, we do need to keep in mind the formulation effect on corticosteroid potency, and that we would be, in essence, increasing the potency of therapy by moving to more occlusive formulation like an ointment. Additionally, we might want to increase that topical corticosteroid strength. So where appropriate, we can consider using higher potency topical corticosteroids if, an adjustment in formulation isn't enough in escalating therapy in order to manage those more severe flare-ups during winter. And of course, during winter, the days are shorter. We spend more time indoors. We spend more time with protective clothing covering a lot of our skin. And so we have less exposure to light, and patients using phototherapy as part of their treatment plan may want to consider adjusting the schedule and duration of their phototherapy sessions in order to accommodate for that decreased sunlight exposure during the winter season. Lastly, if patients are experiencing significant nocturnal pruritus, we can recommend taking those oral antihistamines at bedtime to help manage the itchiness that they're experiencing overnight, improve their sleep and overall quality of life. So in summary, we've covered, what that healthy skin barrier looks like and why, with the disruptions to skin barrier, we're concerned about that progression of atopic dermatitis, how harsh Canadian winters damage the skin barrier, everything from humidity, cold, protective clothing to other stressors like UV radiation, stress, and so forth. We've talked about how to recommend adjunctive therapy as cornerstone, the importance of gentle cleansing and regular moisturization. We spent a lot of time reviewing the components of moisturizers and how to help select a moisturizer, tailor therapy to seasonality, and look at the type of application recommendations that will be helpful to patients in choosing what to apply first. We've also looked at some of the non-pharmacological therapies that will help patients manage their condition and be complementary to the adjunctive and prescription treatments. And we've also talked about some of those prescription treatment modifications that we might want to consider for patients during the winter time. So, in summary, of course, when we want to think about comprehensive management of atopic dermatitis, winter management involves multifaceted approaches. We're going to talk about moisturization, anti-inflammatory treatments, and lifestyle modifications to maintain skin barrier function and prevent flare-ups, as per the American Academy of Dermatology. Thank you so much for joining me today in the review of how to manage patients throughout the winter when they have atopic dermatitis. Thank you again to our session sponsor, L'Oreal Dermatological Beauty, for your generous contribution in the form of an unrestricted educational grant. And thank you to all of you for joining me today for this session and spending your time with me in reviewing these key concepts. Have a wonderful winter, a great holiday, and take care.